Kia ora everyone. This is a slightly different group perhaps than I often would talk to. But
Speak up, please, because we can't hear you.
I can't speak up. I'm a psychiatrist. I'm trained to kind of keep my voice low and mumble incoherently so no one can understand what I'm actually saying. I'll do my best. Thank you. Please yell out if I can't. If you can't hear me at the back. Thanks. I'm Paul Vroegop, and thanks to Sylvia for wherever she's gone. She's probably out cleaning up now. For inviting me to speak. I'm the Paediatric consult liaison psychiatrist here at Counties and have been for about the last 7 years. And I also work half-time in the chronic pain service. And I do bits and pieces of other work within Counties who seem to manage to keep me gainfully employed. I said to Sylvia I would say that I've been doing a transgender clinic this afternoon, so I kind of do lots of different things, which is sort of fun. Maybe it's a bit like working in an emergency department, maybe it's not, but I'm just going to talk to you guys fairly briefly today about acute stress disorder, PTSD, and kind of just some practical stuff. This is the evidence-based guideline, and I think it's a really good thing to talk about when it comes to acute kind of trauma reactions. And for those of you who work as paramedics, or most of you work in ED, I guess there's a lot of myths particularly about pharmacology, and I think it's well worth kind of dispelling some of those things. It's also worth acknowledging that the access to kind of psychological interventions is really, really patchy. It's really patchy here in Counties. I presume it's patchy everywhere else. And it's patchy at primary care, it's patchy in specialty care. So I'm just going to cover trauma, what is trauma from a psychological perspective, acute and chronic stress reactions, so PTSD. Talk a little bit about causations and associations. And sorry, very boring slides, unlike my colleagues who are far more vibrant. You've just got writing to look at, and writing on me, which isn't much of a choice. So trauma from a psychological perspective, I mean, this is kind of teaching many of you guys to suck eggs really, but trauma is essentially an experience of actual or threatened death, serious injury or sexual violation. And it's worth noting that trauma in terms of experiences that can cause stress reactions, significant psychological stress reactions, include obviously trauma itself, but also include things that are really common in hospitals, so procedural trauma. I mean, in paediatrics in the burns unit, paediatric burns dressings on the ward are one of the more kind of repetitive and can be, if they're not done well, if pain management is not done well, really, really distressing. And we see people who have developed significant PTSD. I'll come onto this later from procedures in hospital. Treating 2 people in the chronic pain service at the moment who have really severe PTSD. One experienced it as a treatment-related injury post-cardioversion here in Middlemore, and one had an ICU delirium and has severe PTSD secondary to, and if any of you, those of you who work in ICU, you may know well who I'm talking about, very severe PTSD as an outcome of what most of us would consider sort of normal hospital stay and just a bit of unfortunate bits and pieces. And the other common, or the other experience that it's possible to have PTSD sequelae for is from things like drug reactions and actually even psychosis, which sounds kind of weird, but it's true. So trauma can be directly experienced, but it can also be what we call vicarious. So trauma, and this is in also all the kind of criteria for ASD and PTSD. So trauma can happen to you, trauma can happen to someone else, but you have witnessed it, and you witness the events as it occurs to somebody else. Trauma can happen. You can experience traumatic, trauma from a psychological point of view, knowing or hearing about a traumatic event happening to someone who's close to you or family members. And lastly, pretty much everyone in this room is vulnerable to experiencing repeated extreme exposure to aversive details of a traumatic event experienced by somebody else. So paramedics, police officers and health professionals actually do suffer PTSD secondarily, and it's no less potentially severe. It's less common, but it's no less potentially severe. Does that sound like a complete load of rubbish? Good, right. So look, trauma responses, and again, most of you know this stuff. It's common to experience psychological distress after a traumatic event. It's part of our normal response. It's part of our brain's, it's like pain, it's like a number of other reactions that are part of our brain doing its damnedest to keep us alive, because that's its job. And so acutely, these sort of acute stress reactions are actually adaptive much of the time. And they include things like increased anxiety, hypervigilance, emotional upset, sleep, appetite disturbance, because actually, sort of Maslow's hierarchy of needs, those things aren't so important when you're actually at severe risk for your life. What's important is that your threat response system, your HPA axis, your ability to respond quickly to threatening events is actually at its maximum. So that's what acute stress reactions are all about. They're priming your entire neurological, cardiovascular, your entire body to protect itself in the event of something incredibly threatening happening. And then obviously there's also fear, sadness, guilt, or anger. So quite strong emotions are also very common. And I guess one of the core things is that most people utilise or kind of bring on board their normal support networks, their relationships, whether it's friends or whānau, and their usual coping strategies. And for most people, these psychological symptoms of distress settle down within a few days, at the most a few weeks. But in a minority of people, under some circumstances, people's symptoms persist and they develop acute stress disorder or PTSD. So it's just worth noting that actually, and this is quite interesting, and I wasn't until I went back and had a good look at the literature, I wasn't quite aware of how striking this was. So after severe, significant trauma that you've experienced yourself, about 30% of people will have a psychiatric diagnosis at 12 months post-traumatic event, which is quite high. But if you look at that, PTSD is only 10% so 10% of the total. So a third of the people who have a psychiatric diagnosis. And also, if you think of population-based kind of mental illness, mental health diagnoses, about 15 to 20% of the population, would meet the diagnostic criteria for one of these disorders at any one time over the past year. So it's maybe double, So having a traumatic event increases your risk of a whole lot of negative psychological outcomes. And depression, anxiety, substance abuse are the commonest. So acute stress disorder is where those acute psychological kind of and behavioural responses persist and interfere with your psychosocial functioning significantly. So at that stage we kind of go, well, it's no longer adaptive. Shouldn't really say it's no longer a normal response. I mean, what the hell does that mean? What is a normal response? But it's no longer adaptive, if it's been going on for 2 or 3 weeks. And it's characterised by intrusive memories, negative mood, dissociation. Does everyone know what dissociation is? The kind of zoning out, the sort of, if you think of our acute responses to stress, it's the same as a mouse being pounced on by a cat. It's a fight, flight, freeze, and it's your body, it's your nervous system getting ready to either fight, to run the hell away, or to freeze and hope that the cat doesn't notice it. And if you like, put very simply, dissociation is our version of the freeze response. You see it in most animals, particularly mammals, when threatened. So it's that kind of zoning out, and that can be quite severe. And I mean, mention it a little bit later, but you actually do see. I mean, I've seen people who have a dissociative response where they've had a GCS of 7. I mean, because they're just that completely shut down. They can usually protect their airways, but that's about it, hopefully. And if they can't, then you start to wonder actually if it's dissociative, quite frankly. Just saying. Avoidance is really common, and hyperarousal, so kind of being constantly hypervigilant, constantly on edge. And when you look at the studies following people who've experienced acute trauma, the variation is huge, and ranging from 1% in some studies in victims of sort of just mixed but domestic trauma, if you like, to around 60% in people who are victims of sexual assault. And there's a wide variation in the studies as well, and none of them are particularly of fantastic quality because they're all biased in lots of understandable ways. But risk factors for developing acute stress disorder include violent crime, if you're female gender, younger age, lower socioeconomic status, and traumatic experiences that are perpetuated or of longer duration. And I should add to that, actually, if you already have sort of significant past history of trauma, if you already have significant either current or past post-traumatic stress disorder, that also hugely increases your risk of developing significant acute stress reactions. And it's worth also just acknowledging, acute stress disorder and PTSD do not occur often by themselves. We often see people who have acute stress disorder symptoms, they have the hypervigilance and the avoidance and the dissociation, but they also have significant depression or generalised anxiety. And often substance use, you often may have used substances before, but often substance use becomes a real problem in this group of people because actually substances are what people will often turn to, understandably, to try and damp things down. So I won't go through this in huge kind of detail, but these are the kind of DSM-5 criteria, and they're very similar to the proposed ICD-11. Sort of acute stress disorder and post-traumatic stress disorder are not. They used to be seen as kind of anxiety disorders. They're actually not anymore. It's quite clear that there are a different set of responses neurophysiologically to stress or high levels of threat. But basically you need nine symptoms from any of the following 5 categories. So there are sort of intrusion symptoms. So distressing memories, distressing dreams, waking up with nightmares, dissociative reactions, so zoning out or kind of freaking out, very prolonged psychological or physiological distress in response to triggers that remind them of the event in some way. And when it comes to cues and triggers, it's often the really innocuous things that remind us or that kind of trigger our sort of traumatic responses. It's not the things that we might think of. It's not seeing, a dismembered foot after you've been involved when someone in your family's been killed in a road accident. It can be something as small as seeing a piece of paper lying on the ground. So one of the core facets of this kind of exaggerated threat response is that a lot of strong emotion gets attached to things that actually don't have any real significance for you normally. So that's the kind of core thing. Most people, and this group probably less so than most, most people would kind of go, ugh, when they see something on TV that involves, dismemberment or things like that. But this is often the cues of very normal kind of everyday events. The group of dissociative symptoms, so that altered sense of the reality of one's surroundings. So when you dissociate, it can feel like either you're not real or you're kind of just not quite real. You're sort of fading in and out, or it can feel like actually the world's sort of fading in and out. But also along with that is that sort of dissociative amnesia, that inability to remember particular facets of the traumatic event. And that's incredibly common. Obviously not due to brain injury or concussion or traumatic brain injury, but more a response to, and again, it kind of makes sense. It's the brain protecting you. It's your brain protecting you from what was a really horrible memory, trying to damp things down. And one of the core things about this sort of when acute stress disorder becomes maladaptive rather than adaptive is that people start to do anything to avoid these experiences. So they'll avoid cues that remind them of what happened. They'll avoid sleeping because if they sleep, they start to have nightmares about the accident. And they'll often avoid people. And sometimes this is when it can be difficult to kind of bring in your support networks, your friends, your whānau, because they can start to avoid people who would normally be their primary kind of supports because they're kind of giving them the cues, or all sorts of reasons actually. And then there's arousal symptoms. And the other parts of the criteria, the duration of the disturbance is between 3 days and a month. They can start straight away. Causes clinically significant distress, not attributable to psychiatric disorder, medical condition, delirium or substance. And a couple of things about kids. In children, you may see, instead of repeated memories or nightmares, you may see repetitive play, a kind of very mechanised, and you can kind of, it's a bit difficult to describe, but it's kind of like kids who will just do the same thing over and over again in a very kind of rote way. And you can tell, you just get the feeling there's something wrong with, why are they doing this? It's a kind of concerning feeling, which doesn't sound very scientific, but yeah. Children, they say are older than 6, but often it is that kind of early childhood to early teenagers, will often have frightening dreams, but the content won't relate to the traumatic event or the accident. They'll just have kind of nightmares, all sort of formless fears. So, did I skip a slide? No, I didn't. So, PTSD, just a couple of notes. Really high economic burden. There was the best, and I've got it here, so I'll send it to Sylvia if anyone wants it. One of the best kind of broad overviews, and there's a number of guidelines from which much of this information about treatment is taken from, about the management and treatment for acute stress disorder and PTSD. One of the best and relatively recent ones is Australia. The Phoenix group did a really thorough guideline. They tried to look at also the cost benefit on society, and really it's pretty huge, but a lot of it goes unrecognised. And I'm well aware that it goes unrecognised because I do kind of we often see in our paediatric liaison team, we've often seen, young people who and their families who are significantly traumatised, who they've just sort of sat under the radar. They didn't necessarily come to see us because of that either. But it's also worth noting, I'm not talking about what's often called, and certainly in mental health, complex PTSD, which is kind of on a spectrum, but it describes, people have had the experience of constant or repetitive, very early on relational trauma, so abandonment or abuse or things like that, and then grow as teenagers, as adults, tend to have a more pattern of sort of borderline responses. So very emotionally unstable. So it probably is on the same spectrum of PTSD, but it's not what I'm talking about today. And just because that's my obvious area of interest is chronic pain, and there's a high comorbidity between chronic pain and PTSD, for example. But these are associations, they're not necessarily causation. So a traumatic event is quite likely to, is likely to cause PTSD, and it's also likely to cause chronic pain. And then some of the kind of hyper-arousal, alert threat response pathways, if you like, pain and our pain and our emotional and behavioural responses are linked. They're not the same thing. They're kind of like parallel processes that kind of intertwine with each other. So I think they're both responses of your nervous system, of your body trying to protect you as an individual, and they're both kind of long-term, often quite maladaptive responses. So they're not the same thing. They are quite highly correlated. And I guess I'm saying that because I do, a lot of people I see will say, oh yeah, well they told me that I've got this pain because I've got PTSD. I'm sorry, that's bollocks. There's no evidence for that whatsoever. Right, after getting that off my chest, I'll try not to get distracted. So PTSD criteria, very similar to acute stress disorder. So you need one symptom, you need a stressor, you need one symptom from the intrusion symptoms kind of group, one from the avoidance group, two from negative cognitions and mood, so that's things like dissociative amnesia, the distorted, persistent negative beliefs, and kind of often catastrophizing, expecting bad things to happen over and over again, and that persistent distorted blame. And we see this a lot in parents as well, parents who blame themselves for their kids' injury. So parents with PTSD from their kids' injury is actually incredibly common. And that includes trauma-related emotions and a loss of anhedonia, a loss of interest in stuff that people used to like doing. So a kind of emotional blunting, it's often described as. Feeling alienated, kind of estranged and sort of and detached, and that constricted affect, not being able to actually have positive emotions at all. And then at least 2 of the alterations in arousal and reactivity, so hypervigilance, startle responses, sleep disturbance, concentration, irritability. In kids, it's actually quite common to see really irritable rather than sad behaviour. That's probably the most common. It's got to last for more than a month, have functional impairment, and obviously not be due to medication, illness, substance abuse. And you can say whether or not there are sort of striking dissociative symptoms present. And one of the risk factors is if you have a lot of dissociative symptoms, then you often end up getting medically investigated for a whole lot of other things that probably aren't either particularly helpful or necessary. You end up having EEGs and more brain scans, and that can actually add to people's traumatic experience over time. I'm not saying it's not important to exclude things, exclude organic brain damage or TBI, but it is also important not to focus too much on this must be an organic response. Organic, so-called. I actually hate that word. So what do we do to manage acute stress disorder and prevent progress to PTSD? So one of the things about ASD as a diagnosis is that it doesn't identify many of the people who go on and develop PTSD. So this is in the first 4 weeks post-trauma. Its positive predictive values power is only between 50 and 75%, probably, frankly, most of the studies towards the lower end of that. And pretty poor sensitivity, well under 50% in most of the studies that have looked at it. So it has some utility as a kind of prognostic tool, but it's not hugely. And I guess some of the criticisms are that it may pathologise what are quite potentially appropriate short-term reactions that are going to resolve. And it does overlook non-fear-based responses. So it doesn't take into account people's thinking and spiritual beliefs, for example, and how they might change after an accident. It's very much based on kind of fear responses, and not all trauma responses are fear-based, if that makes any sense. But anyway, that's what we've got. And as I've said before, symptoms really exist in isolation and are considerably higher once you get to post-traumatic stress disorder, reaching a diagnostic threshold. And of course you get a lot of psychosocial problems that are secondary to your trauma. And so, that again, familiar to most of you guys. Pain, other health complaints, relationship problems, financial problems, occupational impairment. And in my corner of the world, I'd say fighting with ACC is a huge one, and it probably creates more psychosocial impairment than just about anything sometimes. So what do we do to prevent PTSD? Well, I mean, the standard early care for people, early helping people is really about helping people use their own usual coping strategies and supports and people around them, and providing them with information. What is going on? What is normal? What's worth worrying about? Kind of when and where to get help. And that's a really challenging one. I mean, who works in the emergency department here? Few. So, would you know who to refer on to if somebody had kind of significant PTSD symptoms, or if you were worried that they might? You would? Fantastic. That's very optimistic of you. Because frankly, I would struggle,
I prefer people that report to Liaison and cycling, especially family members that have seen something terrible.
If they're coming into hospital, yes, but then, it's when they go home. And currently our adult liaison, the paediatric team, we do see outpatients, and we see a lot of these kids, but the adult team just don't have the capacity to do so they only see inpatients. Community mental health, being really frank, it's really, really hard to get someone referred for. And given that the primary treatment for PTSD is psychotherapeutic, it's almost impossible to get psychotherapy without a 9-month wait, by which time you've caused significant problems. So that is one of the challenges. ACC, that's why ACC and the sensitive claims pathway, being the victim of sexual abuse, is actually. I mean, it's a huge positive, because in terms of having that pathway available for that group of people, of trauma sufferers, but it doesn't help everyone else. So. There is some evidence for, if it's clinically indicated, so very high levels of distress, kind of trauma-focused CBT, and I'll touch on that a bit later. There is no evidence for pre-incident preparedness training, although there is some research, quite a lot of research going on it. There's no evidence for stepped care, but again, it tends to be recommended, and there's no evidence for pharmacotherapy. And just be really clear about that, there is no evidence of any quality whatsoever for pharmacotherapy short-term, no matter what papers people might have read. They're pretty crap. Okay? So I can't stress that enough. Not saying it should never be done, but I am saying do not pretend that there's any evidence that giving a beta blocker, giving prazosin or giving benzodiazepines is going to prevent progression or is going to reduce kind of significantly maladaptive stress responses, because there's no bloody evidence that it will. Okay? There is evidence of harm as well. And you probably mostly know this. So one session, structured interventions, so psychological debriefing, which was all the rage for a while, it actually causes PTSD. So you can actually do harm. So don't forget, we all know about the, pharmacology can have side effects and do harm. Psychotherapy equally is just as capable of doing harm, and this is a really good example. And there's some evidence of harm from pharmacological treatments that are used preventatively or in the first 4 weeks. That's not as strong, but the evidence is pointing towards harm rather than any help whatsoever. So, this is, my colleague Catherine, who's a psychologist with our team, wrote this trauma handout for kids. So any of you who work in Kids First will have probably seen it. That's just a subtraction from it. But giving people information, what's kind of normal is actually really reassuring. How long do we expect it to last for? And particularly for parents, it's really, a lot of parents have come back to us and said, oh, just really appreciated knowing, just having a checklist and going, oh, what can we do? What's helpful? What's kind of not helpful? I mean, they're just brief guidelines. They're not particularly complex. And there are similar sort of information things that are out for adults. I just couldn't find our one. So really activating people acutely in terms of stopping progression to kind of PTSD in the long-term difficulties, providing people with information and getting them to supporting them to activate their normal coping strategies are what's key. And treatment for PTSD. So really the main concepts around, the main ideas behind treatment of PTSD is kind of confronting the memory. When I say that, you don't need to confront the actual memory of the actual event, but confronting the memory or confronting the fact that you had an experience. You don't need to. It doesn't need to be about reimagining the details. It's another area of trauma work in which some stuff a lot of stuff in the 70s was done that actually was shown to be harmful. It worsened PTSD if you force people to re-experience things over and over again. So it's really about teaching people to recognise the distress, tolerating the distress, and systematically desensitising them to the cues that are triggering their kind of overwhelming distress. But you have to give people tools to manage that distress before you kind of start desensitising them, if that makes sense. So what there's really good evidence for is trauma-focused cognitive behaviour therapy, which is really cognitive behaviour therapy with a focus on the systematic desensitisation of triggers and cues, and EMDR, which is eye movement desensitisation and reprocessing. And even in mental health, EMDR is still considered kind of one of those slightly weird things because it involves a therapist going like this while getting a patient to talk about something, and not necessarily about something about the actual event. But there's huge evidence that it's a very effective treatment for PTSD. It's a bit harder to access in the public mental health system. Look, it's like a lot of things. I mean, frankly, we don't really know how paracetamol works, do we? So we can hardly criticise EMDR for not understanding why it works, but the evidence says it works well. So, for a majority of people. And for children and adolescents, some trauma-focused CBT and doing that cognitive therapy through the family. Look, there's some evidence for school-based groups. If a group of young people, and this all comes from mass shootings in America, unsurprisingly, have been exposed to the same event, And there's some evidence for a number of other cognitive type therapies, so ACT, acceptance and commitment therapy, interpersonal therapy, problem-solving therapy, and mindfulness all have some evidence that they're probably helpful or useful as a sort of second-line treatment. SSRIs, there is evidence for, but all the guideline recommendations is that they're a second-line treatment after trauma-focused CBT or EMDR, and not for children or adolescents. There's actually evidence that they can do harm in children and adolescents. And acupuncture, interestingly. What there is no evidence for, again, coming back to the pharmacology, there's no evidence for alpha-1 agonists, prazosin. It's very popular. For what reason? I don't know. Maybe because it's cheap, you know, and relatively harmless, I suppose. Alpha-2 agonists, so clonidine. Beta blockers, you know. Propranolol used to be the kind of trendy one, I think, just because you had to give it multiple times a day and people like that. And benzodiazepines. And TMS, transcranial magnetic stimulation. So there's no evidence for any of those. There's not evidence of harm. There's some smallish RCTs that showed no benefit, and there's some other studies that showed benefit but actually were really crap studies. So they're not recommended in any of the guidelines. But, you know, if symptoms haven't responded adequately to psychological treatment, or you cannot access, or the person will not access psychological treatment, pharmacotherapy with an SSRI could be considered. Significant sleep disturbance, again, very time-limited use of appropriate sleep medication can be helpful. I will admit to using benzodiazepines short-term sometimes, because one of the nice things about benzos is that they tend to suppress REM sleep, and if you get someone who won't sleep because they're terrified of the nightmares they have, then it can be a useful intervention just to get things kind of started, but very short term, 2 weeks. And if symptoms haven't responded to an SSRI, you know, you could consider those other things, including risperidone. There was a small trial with olanzapine as an adjunctive medication, switching to an alternative one, upping the dose, reconsidering psychological interventions. And what are the outcomes? Well, you know, good and bad. I mean, the interesting thing is most people with PTSD, even without treatment, actually do end up remitting over time, but it can take a long time. So this is non-treated. 50-60% will pretty much remit most of their symptoms, somewhere between 2 and 10 years. But some people continue to recover, and we see this from, you know, war veterans, particularly from the VA, you know, are improving kind of decades later. But it's a long, slow process for a lot of people. It's much less like treatment means PTSD is less likely to follow a chronic course. So it's the rule of thirds. Oh, just about everything in medicine is the rule of thirds. Yeah. Makes me wonder if we do anything at all sometimes. But so a third will make a good recovery following treatment, a third will do moderately well, and a third won't change at all. But just remember, the majority of people after experiencing a trauma will not develop PTSD. And probably that's around this idea of resilience. And resilience is a kind of difficult, it's a rather slippery concept to get hold of in health. But, you know, I mean, I rather like the dynamic process encompassing positive adaptation within the context of significant adversity. That was, what's his name from the Christchurch study? Richie Poulton? The other one, anyway. But resilience is the usual outcome following a traumatic event. So that's me. A couple of people had put questions, or it might be that Sylvia sent me some patsy questions, I don't know, but I thought I'd try and answer them. Someone asked, what's the evidence for self-care for health professionals? And I guess there isn't particularly good evidence. There are a few studies going on about what kind of works, but I guess it's being aware of the impact on you guys and health professionals of exposure to repeated trauma. So what's really clear is that it can lead to compassion fatigue, burnout, and adverse effects on your ability to deliver good patient care. And in terms of treatment, or I guess management, it's the combination, what tends to be recommended by most of the guidelines is a combination of personal and organisational support. So supervision, being supported to set limits about your professional boundaries, and actually about recognising when you're close to burnout, or recognising when you're overwhelmed or triggered yourself by a particular situation. Being able to say to somebody in your team, actually, I can't do this. And we're lousy as health professionals at doing this. I remember very clearly the first time I ever did that, and it was, I was taking care of a girl in Picker in Starship who was exactly the same age, in fact looked like my tiny daughter at the time, and I just suddenly went, I can't do this, I'm actually going to lose the plot. And I think most of us have those experiences at some time in our lives. We need to be able to step back and go to our colleagues, actually right now I need to step away from this. And it's a really hard thing to do, and I don't think we're well supported to do so.
It's also not well accepted if you do that.
Oh no, yeah, well that's part of it. That's why it's such a hard thing to do, because so I think having those, and that's organisational support around those, and if we can recognise our own levels of stress, then actually I think our colleagues and our organisations have a degree of responsibility to respond to that, because I don't think anyone makes these things up. And somebody had a question about spinal cord injury, supporting a new diagnosis emotionally through our adjustment period. We're really lucky here, as you guys will know, as Alpesh kind of indicated, in terms of psychological support through our SCI pathway, in that in ICU, we have an ICU psychologist, Hamish, who will often work with both a young person and whānau when they're first in ICU. We have the adult and paediatric liaison teams, and he will often follow people to the orthopaedic ward as well. And then we also have psychologists. At the moment, it's Max and John who cover the spinal unit, but actually we've got our locum maternity cover psychologist is just starting the spinal unit as well. And so we're really lucky is that we actually do have sort of psychological support for these families. And when I say support, it's often about identifying kind of what's going on, identifying mental illness, and trying to bring in actually people's whānau and again, activating their normal support networks. So what they do is not exactly magic. It is a lot around supporting them and their family to do what they would do normally. Somebody asked, what's the deal with self-immolators after the event? I'm not quite sure what the context of that was. All I'd say is, if you burn yourself, and having seen a few, I mean, not nearly as many as Richard has, but having seen a few people in the NBC over the years, these are a group of people who've got very high levels of existing psychopathology. What can I say? That stuff needs to be kind of assessed and treated as part of their treatment package. So that's pretty much it. Did anyone else have any other questions? They're the ones, and I think that's where the kind of population level evidence is, that they're the kids who are at higher risk of developing significantly more maladaptive acute and chronic stress reactions, so sort of PTSD. I think there's lots of evidence for that. What can we do? Well, it's a huge question, and it's actually a question for society. The problem is we sit in health and we're one small section of the pie, and they might stay with us for a few days, a few weeks, a few months if they're in NBC, and then they go out into the community. So I guess part of our role when they're in hospital is to try and do what we can to activate some of those community responses to helping parents parent, care and protection, MSD, MVCOT, trying to get NGOs involved, and of course all of that stuff, and trying to get wider whānau in a lot of the time. And sometimes you make some wins, don't you? A lot of the time it feels a bit, it can feel a bit futile, because...
High risk of suicide?
Don't know off the top of my head. PTSD has people with chronic PTSD as adults have quite a high rate of suicide. Higher than depression, but not as high as anorexia or bipolar disorder. Children and the rates of suicide in kids are actually incredibly low, so it's almost impossible to draw any meaningful kind of rates from that. And a lot of it comes down to those, I mean, the longitudinal studies in Christchurch and Dunedin kind of picked out a lot of those that, you know, there are some kids who are exposed to multiple trauma growing up in multiple adverse circumstances, but still manage to do really well. Probably some of that comes down to they just had one or two people in their, you know, lucky genetically, and also usually they had one or two people in their lives who gave a shit, you know, or who could kind of ARFI them along. So I don't have an answer. Sorry, it's kind of a huge thing, and it is a whole of society thing. Yeah. That is why, I mean, I would say for within the organisation, that's why we have an occupational health service, and it's why we have EAP. Now, EAP people have various different experiences for, and personally, I think they should have, I think the DHBs generally should have kept their ability to provide psychotherapy to staff in these sort of situations in-house, because I think we probably used to do it much better. That's just a personal view, frankly. But you know, those are the kind of approaches. So EAP clinicians or psychologists should all have experience in trauma-related therapy. So I would have thought those would be the minimum things that we should be doing, and involving our occupational health team around kind of actually assessing what that staff member needs to support them, whether that's not being at work, whether it's changing their roles, whether it's having, you know, kind of extra things. And I think it's, and you've probably done all of those things, yeah. But it's so, and I think, you know, understanding and recognising that kind of the potential for unhelpful maladaptive traumatic reactions are there in all of us, and we work in an environment where that is, you know, more of us are likely to experience those sequelae, if you like, from exposure to stuff than some other environments. But you know, the highest rates of acute stress disorder and PTSD in professionals are obviously armed forces. Paramedics are pretty close second, so as those of you who are paramedics will know. Yeah. There's a lot of really, it's a good question actually, there's a lot of, did everyone hear that? Yeah, there's a lot of interesting research about that, and it is not clear would be the really evidence-based answer. There's certainly, but certainly there's a strong theme in that you cannot, so the evidence isn't there, but there's certainly a strong theme in a lot of it, particularly the more narrative explorations of people post-trauma, that having no control over your outcomes or over your experience meant you were more likely to experience heightened levels of you know, distress and basically symptoms, which is quite interesting. You know, I mean, and it sort of makes intuitive sense at face value. But interestingly, the kind of evidence when they redid the DSM-5, they couldn't prove that actually that was a significant risk factor. So I don't really know the answer to it. I suspect it is, actually. I think it's just a hard one to kind of tease out. And an example of the you know, I'm thinking of the couple of patients I mentioned earlier who are both you know, medical intervention, if you like, or medically related trauma. You know, both of them have had the experience of having no control and just being completely overwhelmed and out of their depth, and you know, both of them recall us health staff, medical staff, kind of holding them down and what they experienced as being abused at the time. In fact, their lives were probably being saved, but you know, they experienced something very different. Yeah.
That would be my next part of the question. How should that change what we do with these patients with severe?
When it comes to procedural stuff, I'm a huge, and you talk to the psychologists I work with, they would all agree with me, I'm a huge fan of midazolam and opioids. You know, if you can, and midazolam's great, or you know, short-acting benzos. because you tend to get a transient amnesia. So if you know that you need to do something for somebody, it's why you guys use it in ED all the time, you know, because most people actually don't really remember, and they certainly don't tend to remember the levels of distress. So there's lots of evidence for that. So when it comes to procedures, there's actually a lot we can do. I'm slightly more concerned about ketamine. I mean, ketamine can be dissociative and can cause transient amnesia, but it can also heighten people's emotional responses in those kind of situations. So, you know, not necessarily a huge fan, but. Okay, thank you.